taken a pill and just, hope for the best, wondered how it knows where to go, what to do, or why sometimes it feels like it's doing maybe too much or even too little. Well, today we're embarking on this incredible voyage, kind of shrinking ourselves down to follow a tiny drug molecule on its grand adventure inside your body. This deep dive isn't just about rattling off facts. It's really about giving you a shortcut, maybe, to being well-informed about the chemicals you put into your body. We're going to unpack how drugs interact with your unique system, from the smallest cell right up to the biggest influences. It's a fascinating and surprisingly personalized story.
That's exactly right. And the core idea here really is that every single body function, every disease, every drug action, it all starts at the cellular level. Drugs are basically chemical tools. They're designed to alter those basic processes. They can stimulate things or inhibit existing functions, but they can't fundamentally change what your cells are actually capable of doing. And this foundational idea is, well, it's key to everything we'll talk about.
Okay, so let's start right there at that microscopic level. Before a drug can do anything at all, it has to get into your cells, right? Or at least close enough to interact. So imagine your cells as these incredible little worlds, constantly bustling with activity, like tiny dynamic factories. The real question then is, how does a foreign drug molecule, something new, navigate this really intricate landscape?
Yeah, it's a pretty sophisticated navigation system, for sure. The primary challenge is crossing that cell membrane. And the most common pathway, by far, is direct penetration. You can think of your cell membrane as kind of like an oily barrier. Though for lipid-soluble drugs that like oil, it's almost like a drop of olive oil just seeping right through a greasy piece of paper. No special effort needed. It just dissolves its way across. Most systemic drugs are actually designed with this in mind.
Okay, so they just slip right through if they're oily enough?
Pretty much. Then, less common, you have protein channels. Think of tiny gated tunnels. But most drug molecules are simply too large to fit. So these are mainly for small ions, things like sodium, potassium. And then there are carrier proteins. These are highly selective. They're kind of like specific taxis, They pick up certain drug molecules and actively move them across the membrane. It really depends on the drug's chemical structure, whether a carrier will grab it.
So like a specific key for a specific taxi driver.
Exactly. And once across that initial barrier, drugs still need to move around inside. Most do this via passive diffusion, which just means flowing from an area where there's a lot of it, a high concentration, to where there's less. Downhill, basically. So an oral drug, for instance, moves from your high concentration gut into your lower concentration bloodstream until things sort of balance out.
Makes sense. High to low.
Right. But then there's active transport, which is quite remarkable because it can move drugs against that gradient from low concentration to high. And as you might guess, that takes energy. The cell has to actively work, expend energy. It's like pushing water uphill. It needs a dedicated cellular pump.
Oh, okay. Wow. So the cell actually powers that movement.
Precisely. So once a drug has been absorbed using one of these methods, your body takes it on this grand tour. And this whole journey is what we call pharmacokinetics, literally what the body does to the drug.
Ah, okay.
Yeah.
Pharmacokinetics, what the body does to the drug.
Exactly. And it's a really critical journey with 4 key stages. People often use the acronym ADME: absorption, distribution, metabolism, and excretion.
ADME. Got
Yeah.
it. Absorption, distribution, metabolism, excretion.
Each step is critical for how effective and, importantly, how safe a drug will be. And each one has its own fascinating twists and turns.
All right, let's dive into absorption first then, how quickly the drug gets in.
Yeah, absorption is key because the speed of a drug's onset, how fast it starts working, and its overall intensity are largely dictated by how quickly and how much of it is absorbed. A really crucial concept here is bioavailability.
Bioavailability, okay.
That's the actual portion, the fraction of a drug dose that reaches your bloodstream and is truly available to act on your cells. For an IV drug injected straight into the vein, it's pretty much 100%. Makes sense. It's all there.
Right, straight in.
But for oral drugs, pills you swallow, it's almost never 100%. And here's where a fascinating twist comes in. The first pass effect.
First pass effect, what's that?
So when you swallow a pill, after it's absorbed from your intestine, it doesn't just go everywhere immediately. It first travels directly to the liver through a specific blood vessel called the portal vein. This happens before it reaches your general circulation.
A detour through the liver first.
Exactly. And your liver is a major processing plant. It often metabolizes or breaks down a significant portion of that drug right away. So a chunk of the drug is inactivated before it ever gets a chance to circulate through the rest of your body.
Wow. So the liver takes its cut first, basically.
You could put it that way. This liver's silent filter can dramatically reduce a drug's availability. And it's why something like, say, a skin patch, which delivers the drug directly through the skin into the bloodstream.
Bypassing the liver.
Right, bypassing that first pass through the liver might use a much, much smaller dose to achieve the same effect as an oral pill.
That's a truly eye-opening detail. So just because you swallow a 10-milligram pill doesn't mean your body actually gets to use all 10 milligram.
Not necessarily, no. The first pass effect can be quite significant for many drugs.
Okay. So after the drug survives that initial liver pass, or maybe bypasses it like with a patch and gets into the bloodstream, what happens next? How does it spread out? That's distribution.
That's distribution, exactly. Once it's in the bloodstream, the drug molecules travel around. They go to their target sites where they're supposed to work, but also to places where they'll eventually be broken down, like the liver again, or eliminated, like the kidneys. Things like how good your blood circulation is, how easily things can pass out of your tiny blood vessels, your capillaries, play a big role.
Okay.
But what's particularly important here is something called protein binding.
Protein binding.
Yeah, most drugs don't just float around freely in the blood. They temporarily latch onto proteins in your plasma, mainly one called albumin. Think of these proteins as, like, transport buses. The drug hops on. But here's the key. Only the free, unbound portion of the drug, the part that hasn't hopped on the bus, is actually active and can leave the bloodstream to work on your cells.
So the bound part is inactive.
Temporarily inactive, yes. The bound portion acts kind of like a storage reservoir. It releases the drug gradually as the free drug gets used up or eliminated. This helps maintain more consistent blood levels and can definitely affect how long a drug's effects last.
Interesting. So it's like a slow-release mechanism built into the bloodstream itself.
In a way, yes. And this whole distribution thing raises a really critical point for drugs that need to work on the brain. What about the blood-brain barrier?
Right, I've heard of that. It's supposed to be really protective.
Extremely protective. It isn't just a simple membrane. It's this highly selective gatekeeper. It's formed by really tightly packed cells in the brain's capillaries that strictly limit what can pass from the blood into the brain tissue. Only drugs that are very lipid-soluble, very oily, or those that have a specific invitation, like a special transport system, can get across.
So it's like super tight security for the brain.
Absolutely. Which makes designing drugs for neurological disorders like Alzheimer's or depression a huge challenge. You have to figure out how to get the drug past that barrier.
Okay, so our brain has its own VIP section, pretty much. Only certain guests allowed in. Now, once a drug has distributed, done its thing, maybe, it can't just hang around forever, can it? The body needs to clean up. And that process, metabolism, you said that's next. And it can lead to some unexpected results.
Absolutely. Metabolism, or the technical term is biotransformation, is next. This happens primarily in the liver, although other tissues play a role too. Your body's main goal here is generally to take active drugs, which are often lipid-soluble, and convert them into inactive, water-soluble forms.
Why water-soluble?
Because water-soluble things are much easier for your kidneys to excrete in urine. It's your body's chemical waste disposal system. But yeah, sometimes it has surprises.
Like what?
Well, for instance, some drugs, known as prodrugs, are actually swallowed in an inactive form. They don't do anything until your liver metabolizes them into their active form.
The liver actually turns them on.
Exactly. Codeine is the classic example. You take codeine, but it doesn't do much for pain until your liver converts it into morphine. Morphine is the active drug.
Huh. That's counterintuitive.
It is a bit, yeah. And the liver enzymes that do most of this work are called the cytochrome P450 enzymes, often shortened to CYP enzymes.
CYP enzymes, okay.
These guys are the superstars. They're like your body's main drug processing team, handling the breakdown of the vast majority of medications you might take.
So this team, these CYP enzymes, they're always working at the same speed.
No. And that's where it gets really interesting and complex. This team isn't always consistent. Some drugs can actually cause enzyme
Induction, like encouraging them.
Exactly. They make your liver produce more of these metabolizing enzymes over time, usually over a few weeks. This speeds up the metabolism not only of that drug, but potentially others too, which might mean you end up needing larger doses of a drug to get the same therapeutic effect.
Because your body gets better at breaking it down faster.
Right. And then there's the opposite. Enzyme inhibition. This happens when one drug slows down the metabolism of another drug, often because they're competing for the same CYP enzyme, like too many people trying to use the same checkout lane.
Okay, so a bottleneck.
Pretty much. This can happen much faster, within hours or days. And the consequence? The drug that's being blocked can build up in your system. Levels get too high, increasing the risk of toxicity of side effects. For example, some common stomach acid producers, like cimetidine, are well-known inhibitors of several CYP enzymes and can cause problems with other medications.
Wow. So taking one drug can actually change how your body handles a completely different one. That sounds potentially dangerous if you're not aware of it.
It absolutely can be. It's why it's so critical for doctors and pharmacists to know all the medications someone is taking, including over-the-counter things and even supplements.
That makes sense. So the liver is this dynamic chemical plant,
Yeah.
constantly adapting. You mentioned induction can take weeks. Is that a common pitfall people miss, assuming these interactions are instant?
Yeah, that's a good point. Underestimating the time course is common. Induction takes time to build up and also time to wear off if you stop the inducing drug. Inhibition can be faster, but the consequences might build up over days. So after metabolism, the drug or its metabolites needs to leave the body. That's the final step, excretion.
Getting rid of it. Mostly kidneys.
Primarily through the kidneys and urine, yes. But drugs can also be excreted through bile, produced by the liver, which ends up in your feces. And some volatile substances, like alcohol or anesthetic gases, can actually be exhaled through your lungs.
Didn't think about the lungs.
Yeah. And there's another interesting loop here called enterohepatic recirculation.
What?
Enterohepatic recirculation. Some drugs excreted in the bile can actually get reabsorbed from the intestine back into the bloodstream. They take this little detour, go back to the liver, maybe get processed again, and eventually leave via the kidneys.
So they get recycled.
Kind of. This loop can significantly extend how long a drug stays in your system and keeps working.
Wow. The body is complicated.
It really is. And the kidneys, as the main exit route, are just crucial. If someone has impaired kidney function, especially severe renal disease.
They can't get the drug out properly?
Exactly. Drugs accumulate, levels rise, and dosages must be reduced to prevent potentially severe adverse effects. This is a vital consideration for many patients, especially, for instance, older adults. Think about someone like, the case study mentions Doris Green, an 89-year-old. With age, kidney function naturally declines, making excretion less efficient.
Right. So for someone like Mrs. Green, that slower excretion is a big deal.
A very big deal. And to manage all this, to make sure drug levels are right, we often measure serum drug levels.
That's in the blood.
Yep. A lab measurement of how much drug is in your blood at a particular time. This helps us define the minimum effective concentration, MEC, the lowest level needed to actually work.
Yeah.
And the toxic concentration, the level where it starts causing harm. And importantly, that sweet spot in between, the therapeutic range.
The Goldilocks zone. Not too little, not too much.
Precisely. That's where you want the drug level to be for optimal benefit with minimal risk.
So the therapeutic range is really the target. And how does something like a drug's half-life play into keeping it in that range?
Good question. The serum half-life, or elimination half-life, is simply the time it takes for the drug's concentration in your blood to decrease by half, by 50%.
Okay.
So practically, a drug with a short half-life, say just a few hours, needs to be taken more frequently to stay in that therapeutic range, whereas a drug with a long half-life, maybe 24 hours or more, might only need once-a-day dosing.
Makes sense.
And it also tells us something important about reaching consistency. It generally takes about 4 or 5 half-lives for a drug level to reach a steady state in your body. That's the point where the amount going in roughly equals the amount going out, and you get consistent therapeutic effects.
4 or 5 half-lives to get steady. Okay. So we followed the drug on this epic journey through the body, ADME. Pharmacokinetics. Now let's flip the script. Let's talk about pharmacodynamics, what the drug actually does to your cells, to your body. This is where the magic or the effect happens, right?
Exactly. Pharmacodynamics is what the drug does to the body. And most drugs exert their effects by chemically binding with specific targets on or in your cells, primarily receptors.
Receptors, like docking stations.
That's a great analogy. Think of the receptor as a lock on the cell surface, or maybe inside the cell. The drug molecule is the key. When the drug key fits into the receptor lock, it forms a complex. And this drug-receptor complex then triggers a response inside the cell. It might activate an enzyme, or open or close an ion channel, or change how the cell makes or releases certain chemicals. Basically, telling the cell to either step on the gas or hit the brakes on its normal activities.
Okay, lock and key triggering an action.
Right. And it's really crucial here to differentiate between two main types of drug keys, agonists and antagonists.
Agonists and antagonists.
Agonists are drugs that, when they bind to the receptor, they activate it. They mimic the effect of your body's own natural substances, like hormones or neurotransmitters, so they stimulate a cellular function. An example might be a drug that acts like adrenaline to increase your heart rate.
Okay, agonists activate, turn things on.
Correct. Antagonists, on the other hand, bind to the receptor, but they don't activate it. They just occupy the space. They act like a blocker. They sit in the lock, preventing the body's natural keys or maybe other agonist drugs from getting in and turning it on. So they inhibit or block cell function.
So antagonists block, turn things off, or prevent them from turning on.
Exactly. And these receptors, these locks, they aren't static. They're actually dynamic cellular components. Your cells can make more or fewer receptors or make them more or less sensitive.
Pick and chain?
Yes. For instance, if a receptor is constantly being stimulated by an agonist drug over a long time, the cell might respond by reducing the number of receptors or making them less sensitive. That's desensitization or downregulation. The drug becomes less effective over time.
Ah, tolerance could be related to that.
It certainly can be one mechanism contributing to tolerance. Conversely, if a receptor is constantly blocked by an antagonist, the cell might respond by making more receptors or increasing their sensitivity. That's upregulation. And this dynamic nature is really important. It explains why some drugs, particularly those affecting the brain, absolutely must be tapered off slowly when stopping them.
Why is that?
Because if you suddenly stop an antagonist, for example, after the body has upregulated its receptors, those now super-sensitive receptors can be overwhelmed by the body's natural substances, leading to exaggerated withdrawal symptoms or a rebound effect. You need to give the body time to readjust.
Right, let the receptors recalibrate slowly.
Precisely. And it's worth noting, just quickly, that not all drugs work via receptors. A few act through simple physical or chemical interactions. Think of antacids, they just chemically neutralize stomach acid and no receptor needed. Or osmotic diuretics, which basically just pull water out of tissues by osmosis. Or certain agents that bind directly to toxic heavy metals to help your body excrete them. Direct action, no lock and key involved.
Interesting. So mostly receptors, but a few exceptions. Okay, so after hearing all about how drugs journey through the body, ADME, and then how they actually do their job, pharmacodynamics, you might be thinking, okay, but if everyone takes the same drug, why do we all seem to react so differently? And this is where the individual equation really comes in, right? Your response to medication is this complex interplay of so many variables, making it a truly personalized experience.
Indeed it is. And we can sort of group these variables into drug-related factors and patient-related factors. On the drug side, dosage is obviously a major determinant. Sometimes doctors use an initial larger loading dose to get drug levels up into that therapeutic range quickly, especially for serious conditions. Then they switch to a lower maintenance dose to keep the levels steady. But even standard recommended doses are really just guidelines. They always need individual tailoring.
Right, starting points.
Exactly. And the route of administration, as we touched on, IV is fastest, oral is slower. That profoundly affects how quickly and intensely a drug acts too.
Okay, dose and route.
Yeah.
What else on the drug side?
Well, something really fascinating and maybe often overlooked is drug-diet interactions.
Food. How can food affect a drug that much?
Oh, dramatically. Everyday food choices can really alter drug effects. There are some classic examples. Certain antidepressant drugs, the MAO inhibitors, can cause a dangerous spike in blood pressure if you eat foods high in tyramine things like aged cheeses, sauerkraut, certain cured meats, red wines, draft beers.
Wow, cheese and wine could be dangerous.
With that specific class of drugs, yes, potentially vary. Or vitamin K, found in spinach and leafy greens, can counteract the effects of the blood thinner warfarin. Dairy products can bind to the antibiotic tetracycline in the gut, preventing it from being absorbed.
Okay.
And then there's grapefruit juice.
Grapefruit. I've heard about that one.
Yes. Grapefruit, and also grapefruit juice, is a really potent inhibitor of one of those key liver enzymes we talked about, CYP3A4. Drinking grapefruit juice can significantly increase the blood levels of many common drugs, including some statins for cholesterol, blood pressure meds, anti-anxiety drugs, because it slows down their metabolism in the gut wall and liver.
Increase them by how much?
Potentially by a lot, enough to cause side effects or even toxicity. And the effect can last for several days after just one glass of juice.
For days. Seriously.
Seriously, it's generally recommended to just avoid grapefruit entirely if you're taking certain medications. It's a compelling reason to always check for these kinds of interactions.
Definitely noted. Avoid the grapefruit.
Okay, so that's diet. What about mixing different drugs? Drug interactions. That sounds incredibly complex, especially for people taking multiple medications. Are there like a few key things to watch out for?
The golden rule, honestly, is just complete transparency. Always make sure your doctor and pharmacist know everything you're taking: prescriptions, over-the-counter meds, vitamins, herbal supplements, everything.
Full disclosure.
Absolutely.
Yeah.
Because interactions can happen in many ways. You can have additive effects where two similar drugs just amplify each other's effects. Think alcohol plus a sedative, both slow down the brain. The combination does it more.
Okay, 1 + 1, 2, or maybe even 3.
Right. Or you can have synergism, where two drugs with different mechanisms work together to produce a greater effect than either could alone, like combining acetaminophen and codeine for better pain relief.
But 1 + 1 equals like 4, something like that. We also already mentioned drugs interfering with each other's metabolism via those CYP enzymes. One drug slowing down the breakdown of another, leading to high levels. And another important one is displacement from protein binding.
Displacement, like pushing another drug off those protein buses in the blood.
Exactly. Remember, only the free drug is active. Well, if drug A bumps drug B off its protein binding sites, suddenly there's a lot more free active drug B floating around. A classic example is aspirin displacing the blood thinner warfarin. This can suddenly make the warfarin much more potent, increasing the risk of bleeding. It's like that game of musical chairs in your bloodstream. If a drug gets bumped off its protein seat, it's suddenly free to act, maybe too strongly.
Wow. So many ways drugs can interfere with each other.
Yes, and some interactions actually decrease effects too, like antidotes or drugs that block absorption, or those enzyme inducers we talked about that speed up metabolism. It's complex.
Okay, so those are drug-related things.
Yeah.
What about us? The patient-related variables, how do we differ?
Oh, hugely. Your age plays a massive role. We know neonates and infants handle drugs pretty inefficiently because their organs, liver and kidneys especially, are still immature. Interestingly, young children, say 1 to 12 years old, can sometimes metabolize certain drugs faster than adults, which might require different dosing strategies.
Faster.
Yeah. But then, at the other end of the spectrum, older adults. Let's think about Mrs. Green again, the 89-year-old case study. She's likely taking multiple medications for cardiovascular and maybe renal issues. She faces numerous challenges. As we age, lots of things change physiologically. Often there's decreased stomach acid, maybe reduced blood flow to organs, cardiac output might decline, and importantly, liver and kidney function generally become less efficient.
So slower processing and slower getting rid of drugs.
Exactly. Slower metabolism, slower excretion. This means drugs tend to hang around longer in older adults, increasing the risk of accumulation and adverse effects if doses aren't adjusted downwards. So for patients like Mrs. Green, very careful monitoring and often lower doses are absolutely critical.
That makes a lot of sense. Age is a big factor. What else about us?
Well, body weight is often considered, especially for certain drugs where the dose is calculated based on weight, like melodring per kg.
Simple.
And then here's where it gets really cutting edge and incredibly important for the future of personalized medicine. Pharmacogenomic variations?
All right.
Or pharmacogenetics?
Genetics. Our genes affect how we respond to drugs.
Massively. The core idea is that your unique genetic heritage, your DNA blueprint, can drastically alter how your body processes drugs, especially how quickly or slowly your CYP enzymes work.
Those liver enzymes again.
They're central. Your genes dictate which versions of those enzymes you have, and some versions are super fast processors while others are really slow, and some might be intermediate.
So my genes determine my enzyme speed.
Largely, yes. And this genetic blueprint explains why a standard dose of a drug might be perfect for one person, dangerously toxic for another person with slow enzymes because the drug builds up, or completely ineffective for someone with ultra-rapid enzymes because they chew it up too quickly.
Wow. Give me an example.
Sure. There's a tuberculosis drug, isoniazid. Some people are genetically slow metabolizers and need lower doses to avoid nerve damage. Others are rapid metabolizers. Or consider codeine again. We said it needs CYP2D6 enzyme to become morphine. Some people, particularly certain Caucasian populations, have genes for a very poorly functioning CYP2D6. For them, codeine gives little to no pain relief because they can't activate it properly.
So it just wouldn't work for them.
Right. But on the flip side, there are ultra-rapid metabolizers who have multiple copies of the active CYP2D6 gene. They convert codeine to morphine very quickly and efficiently. This can lead to dangerously high morphine levels even from standard doses, increasing the risk of serious side effects like respiratory depression. The FDA even has warnings about this.
That is mind-blowing. The same pill can be useless, perfect, or dangerous, all depending on your genes.
Precisely. And we're seeing more and more genetic tests being used to predict these responses, allowing for more personalized dosing. It's a huge area of research.
Incredible. Okay, what other patient factors?
Well, related to genetics is ethnicity. We see certain patterns in drug response that differ, on average, between ethnic groups. For example, in treating hypertension, people of African American descent may respond less well to certain classes like ACE inhibitors or beta blockers, but often respond better to diuretics or calcium channel blockers compared to Caucasians. People of Asian descent may sometimes require smaller doses of certain drugs. These are generalizations, of course, and genetics plays a big role within groups too.
Okay. And what about sex? Differences between men and women?
Yes, and this is an area that historically got less attention, with research often done primarily on men, but we now know there are significant differences. Women might respond differently to antidepressants, need smaller doses of some antipsychotics, or experience pain relief differently with opioids versus non-opioids compared to men.
Why is that?
Several reasons. Differences in body composition, fat distribution, muscle mass, total body water, blood volume, hormonal fluctuations play a role. And there are pharmacokinetic differences too. Women might have higher blood levels of some drugs due to slightly different distribution volumes or slower kidney filtration rates. And even differences in the activity of those CYP enzymes. Some might be faster in women, some slower.
So potentially more side effects for women with some drugs.
Yes. Studies suggest women are generally more likely to experience adverse drug effects, highlighting the need for careful monitoring and potentially different dosing strategies.
Really important to consider. Okay, quickly. Any other patient factors?
Sure. Pre-existing conditions are huge. Obviously, liver disease or kidney disease will significantly impair drug metabolism and excretion. Heart failure can affect distribution. Thyroid disease can alter metabolism rates. Even psychological factors can play a role, things like the placebo response or how a person's attitude and expectations might influence whether they actually take the medication as prescribed.
Right, compliance.
And finally, tolerance and cross-tolerance. Your body can adapt. Drug tolerance means you need larger doses over time to get the same effect classic with opioids or alcohol. And cross-tolerance means being tolerant to one drug can make you tolerant to other related drugs, like alcohol tolerance affecting how you respond to sedatives. This can be due to those enzymes getting induced or receptor sensitivity changing.
Wow, okay. That is a lot of variables influencing how a drug works in any one person. It's way more complex than just taking a pill. So with all these complexities, all these individual variations, it's absolutely crucial to understand that all drugs, even over-the-counter ones, carry risks. So what happens when things go wrong? When a medication has an undesired impact, an adverse effect, or worse, leads to an overdose.
Right. Adverse effects are basically any undesired responses to a drug. They can range from mild, predictable side effects like drowsiness or nausea to severe, unexpected, or even life-threatening reactions. They can impact nearly any body system. You might see effects on the central nervous system like agitation or seizures or excessive sedation. GI effects like severe nausea, vomiting, bleeding, or diarrhea are common. Effects on the blood, like problems with clotting or bone marrow function. Liver damage, hepatotoxicity, is a concern with many drugs, like high doses of acetaminophen. And kidney damage and nephrotoxicity can occur with drugs like gentamicin.
So they can hit almost anywhere.
Pretty much. And then there are hypersensitivity reactions or allergies. These are particularly tricky because they're largely unpredictable and usually unrelated to the dose. They happen because your immune system mistakenly reacts to the drug. They can range from a mild skin rash or hives all the way up to severe, life-threatening anaphylactic shock, which involves difficulty breathing, plummeting blood pressure, swelling. It's a true medical emergency requiring immediate treatment, usually with epinephrine.
anaphylaxis. That's terrifying.
It is. And there are other rarer adverse effects too, like drug-induced fever or idiosyncratic reactions, which are totally unexpected based on the drug's known actions, often due to a specific genetic variation. Drug dependence, carcinogenicity, or teratogenicity causing fetal abnormalities if taken during pregnancy are also critical considerations.
So many potential downsides. How do we get warned about the really serious risks?
Well, regulators like the FDA have safety signals. The most prominent is the black box warning, or BBW. This is the FDA's strongest warning, reserved for drugs with potentially serious or even life-threatening adverse effects. You'll see it prominently displayed, often right at the beginning of the drug's official prescribing information or label. It really highlights a major risk clinicians and patients need to be aware of.
Okay, the black box means pay serious attention.
Definitely. And regarding pregnancy, the older A, B, C, D, X categories that people might be familiar with are actually being phased out. They're being replaced by a newer labeling rule that provides much more detailed, evidence-based information about the risks during pregnancy and lactation, including data from human exposure registries when available, and information on potential effects on fertility. It's designed to be more helpful for clinical decision-making.
Good to know that's improving.
Yeah.
Now, what about outright toxicology or drug overdose when some takes way too much?
Right. Drug toxicity or overdose results from excessive amounts, either accidental or intentional, and it can cause significant damage to body tissues. It's unfortunately a common and very serious problem.
What's the first thing someone should do if they suspect an overdose?
Okay, immediate action is critical. If the person has collapsed, is having seizures, or isn't breathing, call 911 immediately. Don't hesitate. If the person is awake and responsive, but you suspect an overdose, you should immediately call the National Poison Control Center. The number is 1-800-222-1222.
1-800-222-1222.
Yes, say that number. They provide expert advice 204/7. The main goals in treating an overdose are first, support vital functions, breathing, circulation. Second, try to prevent further damage, often by reducing absorption of the drug if possible. And third, if available, administer specific antidotes.
Okay, reducing absorption. How do they do that?
One of the main tools, especially if the person gets treatment fairly quickly after swallowing the substance, is activated charcoal.
Activated charcoal, the stuff in water filters.
Similar principle, but medical grade. It's often called the universal antidote, though that's a bit of an overstatement. It works by adsorption, basically. Toxins and drug molecules stick to the surface of the charcoal particles in the GI tract, preventing them from being absorbed into the bloodstream. It's like a molecular sponge. It's generally most effective if given within about 30 to 60 minutes of ingestion.
But it doesn't work for everything.
No, that's important. It's not very effective for things like alcohol, iron pills, lithium, or heavy metals. And administering it requires care, especially if the person is drowsy or unconscious, to make sure they don't breathe it into their lungs. The airway needs to be secure.
Okay. What about things like making someone vomit or pumping the stomach? I remember hearing about those.
Yeah, methods like using ipecac syrup to induce vomiting or routine gastric lavage stomach pumping are generally no longer recommended.
Oh, really? Why not?
Studies have shown they often remove only a small amount of the drug, especially if time has passed, and they carry risks of complications like aspiration. So they're rarely used now. Activated charcoal is generally preferred when appropriate.
Good to know that's changed. Are there other methods?
Sometimes, for certain types of overdoses like sustained release pills or maybe illicit drug packets that someone swallowed, a technique called whole bowel irrigation, WBI, might be used basically flushing the entire GI tract out. In some specific cases, like aspirin overdose, changing the urine pH can help the kidneys excrete the drug faster. And for very severe poisonings with certain substances like lithium or massive aspirin overdose, hemodialysis filtering the blood with an artificial kidney machine might be necessary.
Dialysis. Wow. And you mentioned antidotes.
Yes, when a specific antidote exists, it can be incredibly effective. The classic example is naloxone for opioid overdose drugs like heroin, fentanyl, or prescription painkillers. Naloxone directly reverses the opioid's effects.
Like Narcan.
Exactly. Narcan is a brand name for naloxone. But one crucial thing to remember with antidotes is their own half-life compared to the toxin's half-life. Naloxone, for instance, has a relatively short half-life. The opioid might last much longer in the body. So even after giving naloxone and the person wakes up, the opioid effects can return later, meaning repeated doses of the antidote are often necessary.
That's critical. The antidote might wear off before the drug does.
Absolutely vital point in overdose management.
Wow. What an incredibly detailed journey we've taken. From watching a tiny molecule trying to sneak past the cell membrane to seeing it processed by the liver, distributed around doing its job at a receptor, and then all the ways you, your genetics, your age, even your lunch can change absolutely everything. Understanding these basic concepts, pharmacokinetics, what your body does to the drug, and pharmacodynamics, what the drug does to your body, it really isn't just academic jargon, is it? It's truly about empowering you to be a more informed, more active participant in your own healthcare.
It really is. And if we think about the bigger picture here, especially with the advances in pharmacogenomics we discussed, it really points towards a future where drug therapy could become truly deeply personalized. Imagine moving beyond a mostly one-size-fits-all approach. Instead, your medication regimen could be precisely tailored to your unique genetic blueprint, aiming to maximize the benefits while minimizing those risks we talked about. So the provocative thought maybe is, what does that potential future mean for how we approach medicine, how we think about managing our health, and maybe even our own responsibility in understanding our unique biological makeup?
A really powerful thought to ponder as you continue your own deep dives into knowledge. Thank you so much for joining us on this one.